Thank you very much, Pavel. And I will say from the outset that all of this was a complete mystery to me. Apart from bits that you sort of hear bandied around with cancer trials about Bayesian statistics, etc. And I hope what I'll be able to demonstrate slightly fearfully, that even clinicians can sort of have a very slight clue, and I emphasize the word slight there. There is nothing more terrifying than sitting here with two statisticians you've worked with and then the head of statistics at the Southampton Clinical Trials Unit as well. So I feel like I've got a tripod of judgment in front of me. So I'll stop looking at you just in case you make me nervous. I don't want to labour the point too much, but let's go back to February 2020. None of us particularly want to, but let's think about it. And really, February was the month where things really began to get going. We began to see what was happening in China. We were seeing that this had spread across the world now into Italy, first cases in the UK. And of course, it didn't take a genius to realise that things were going to get a lot worse and going to get a lot worse very quickly. And those early weeks on the wards, of course, were horrendous. As people have already talked about today, you were essentially looking at people and going, bit of oxygen, maybe some antibiotics, and that's about it. So we needed to have new or repurposed therapies now. I won't labour on this because Say's already talked about this, but essentially one of the big things with Agile was to try and reduce the very long period of time that exists and the lots of money that it costs to do in drug development from the sort of conservative 6 to 7 years to something that more represented the urgency of the situation. And you'll notice there that sort of combined, and I'll try not to blind anyone with a laser pointer, I can't guarantee that, combined the phase 1 and phase 2 portions, which were something that we felt very strongly about. And so what we wanted to do to get this to work was to make sure that we identified promising candidates and we made them move through the system much more quickly. We wanted to get rid of the stuff that didn't work, right? So stuff that was not working, we needed to get rid of that. We've already kind of talked about decision-making, but of course, decision-making in clinical trials can sometimes be quite slow. And so how do we utilize these different methodologies to try and build that up and speed it up as well? And we wanted the ability to test multiple candidates all at once. But fundamentally, what we didn't want was something like this, okay? So talk a lot about acceleration, but what we don't want are the well-known disasters that have happened in clinical trials, such as Tegenera and TGM-1412 in 2006, and then more recently in 2016 in France at the biotrial unit in Rennes. So that's the bit we absolutely wanted to avoid. And the question was, is there anything here that we might be able to do? Now, again, forgive the non-statistical language on this notice board, but this is the actual notice board after a conversation that Say and I had while I was at home, and he sort of asked the question, can we do something where we can test lots of different things all at the same time? And this is what we drew out on the board. This was the first iteration of what became the Agile trial. And actually, some of this actually came to pass. So it was a platform study. We had lots of different candidates. There is a vague normal distribution curve here. No idea what the hell that's doing there. I think it was something to make it look vaguely official, but I can't remember why it was there. And sort of things about stopping rules, how we share data, etc. It's also a great board because it does show what was happening at the pandemic. So this is us trying to work out what the hell we do with our junior doctors, where they're going to be working and be redeployed to. And then all of the long list of things that we needed to do to get the research unit ready for COVID. So this is all in February. And so essentially, after we involved people that actually knew what the hell they were talking about, so in SCTU and Jack and Pavel, we came up with this idea that this should be a platform trial based in statistics for robust decisions, and we would focus primarily on first in human phase 1, phase 2A. And so what does Agile look like? Well, in a very basic sense, Agile sat in the space just after the sort of preclinical testing, modelling, etc. And we sort of sat in that space between first in human phase 2A. Importantly, we would do whatever the drug needed us to do. So if the drug was ready to go into a phase 2A trial, we would shove it in there. If it was first into COVID in a 1B, we would do it there, but we would also do first in human. And this was all largely in COVID patients. Because of the platform trial design, we were able to tailor endpoints to fit the drug so that it looked at what was the relevant outcome for that compound. We made sure it was seamless so we could move through phase 1 to phase 2 with very little pause. And it was designed to be very efficient. And I think it genuinely was. Well, I say is, because it's still going to this day. So we've already talked a little bit about platform trials, but I think it's worth just emphasizing why the platform trial design was a good one, was because it gave us all of the sort of flexibility to add or drop arms, to amend the sample size as we went along, to make sure our outcomes were relevant to what we were doing in that particular part of the study. To share control data where we could, that was actually relatively challenging because we've talked about the virus constantly changing. So a control participant with Delta is very different from a control participant with Omicron variants, for example. And we can adapt to the changing circumstance. I don't, Say said in his talk that I think we all knew was going to be changes. I don't think we realised quite how many changes there would be and how different the trial would look. And then just to point out again, the bits that we talked about, opportunity costs, or something they talked about. So this was our clinical research facility then. It's actually very different now because we're in a new hospital. But we divided our clinical research facility into a red zone, so you can see it all marked up here, so that the red areas are where the patients would be, the yellow areas are where the staff were circulating. We had to create new teams, so red teams and green teams, so that we could avoid cross-infection. And the important thing was that this wasn't just a Liverpool thing, right? So this was a rollout across lots of different clinical research facilities in the United Kingdom. And so we had to work out strategies that other CRFs could then copy us so that they could run these trials. It was very important that we rapidly deployed. And then things like data, data was hard to handle, as we all remember, in the pandemic, because there wasn't really much on-site monitoring. So we're having to do virtual monitoring, which has its challenges. And we needed platforms that would allow us to do that. Thankfully, SCTU used Medidata Rave, which actually made things very easy across the country. And then we would do crazy things, crazy things. So we have a picture here, incriminating picture here of our senior research nurse and laboratory manager, one of our research assistants, and then Professor Tom Fletcher and Professor Lauren Walker there, as we were emptying out the hospital in order to create sort of hubs for us to screen and dose patients up close to where they are. So this is in St Helens in Merseyside, about 10 miles outside the centre of Liverpool, in a hot hub where the GPs were seeing COVID patients. So we did everything we could to try and make the trial work as a sort of consequence. You notice how I'm dwelling on this part before I go on to the Bayesian part, because this bit I feel much more comfortable about. Feeling distinctly nervous about the next few slides. So let's think about Agile's design and how it actually works. So obviously there you have your COVID-19 patient, and we would then screen, consent and randomise, often in the same day. So because we needed participants who were fresh, if you like, that were as close to symptom onset as possible, we would screen, consent and randomise as quickly as we could do. And we would screen, consent, randomise and dose on the same day in some cases. And then we would move into, for candidates who were going through the sort of dose escalation part, we moved into this sort of very rapid fire dose escalation. So we would have our sort of escalating doses, 1, 2, 3, 4 here. We would collect data up to day 7, even though they were being followed up to day 28. But day 7 was where we drew the cutoff line, and then those data would be reviewed through the safety review committee, and that was when the model helped us understand exactly what our next dose level should be in the dose escalation. We've talked about estimating of priors. I'm going to talk about that a little bit later on in another slide. But obviously, the model was defining what we consider to be a target toxicity level or an acceptable range of toxicity. Once this was done, we would move stuff into a seamless progression into a phase 2A study. Interestingly then, as you might expect, the outcomes changed. And then we had a Bayesian analysis, which again, normally when I'm giving this talk, I just sort of hide behind that and go, yeah, Bayesian analysis, it was great. But unfortunately today I'm going to have to talk a little bit more about that. So let's talk about the Bayesian model and how it works. And obviously, Jackson already brought this up, okay? So the simple part of the Bayesian model is that we start with what we think, we gather data, and then it looks at that once it has the data. And what we said for phase one was that we need to be clear about safety, but we also need to be pragmatic to the fact that we're in the middle of a pandemic. So we wanted a prior that was set to maximize the probability of accurate dose selection for phase two. We said that doses were unsafe if there was a more than 25% chance that treatment gives a 30% higher dose-limiting toxicities over controls. And we defined dose-limiting toxicities, unsurprisingly, as adverse events that were above CTCAE or equal to grade 3. And then we would try and select the dose, the model, would try and select the dose that was closest to the 20% increase in DLT with a plus or minus 5% at either side. To satisfy the regulators, although there is a prize, there is no prize, for spotting where we didn't do that later in the presentation, where actually we went above double the last dosing tier. But in order to make the regulators happy that the model, we weren't going to go crazy, that we would keep it within a twofold dose increase. For those that are interested, this is a great paper, and I understand about the first 2 paragraphs, and then it's lost on me. But what this does do is that talking about the priors and the stuff that we've already talked about today is how you might go about choosing those priors and how they were done in tandem with clinicians. So, for example, setting the sort of target additional toxicity rate, the tolerance around that target, etc., and again, upper toxicity bound. This was working between the statistics team and the clinicians to try and define that. One of the things I think is very important is that to have those conversations on that level, and as Jack was saying, there is that challenge, isn't there, about explaining statistical terms to non-statisticians. And actually that was something that the team did really, really well, because at least I understood it. Say you understood it better than I, but definitely it was something we could understand. And I'm not going to dwell too long on the side, but you're going to see more of these. These are the dose toxicity model plots. And this is what we would get. So you'd have dose 1, dose 2, dose 3, dose 4. And as you started to accrue data, this would change. We'll see this. And then when you're running the simulations, again, not something I was ever involved with, is that you want to be in a position where you can dose escalate. So as you can see in this starting dose here, the density of sort of risk is very much at this lower end. The 2 dotted lines here represent where we want it to be, between the 15 and the 25% sort of thing. And then obviously as you start to accrue, you start to increase the dose, then your curve, your sort of area under the curve flattens out, and so uncertainty increases. But one thing that doesn't change is that the probability that the target toxicity is in that range doesn't change vastly between these 3 doses, which emphasizes that the model is performing reasonably well. And then when we come to phase 2A, things change, because here what we're looking at is the efficacy. Now, quite often, initially, that was on the basis of virological response. So it's already talked to us about the challenges of that, but for early on, that's how we went about it. And we said, well, again, we will define futility as a probability of a hazard ratio greater than 1 is less than 33%, and efficacy if the probability of a hazard ratio greater than 1 is 80%. And we would look at that in interim evaluations as part of the trial going through. So we would try and kill early if we needed to, or promote early if we could do. And these are the sort of trials that I'm going to talk about today, mostly on CST2 and CST3, because they're interesting examples. One of the things that I'm hoping to get across to you today is the vast difference between all of these individual trials in the platform, so demonstrating the adaptability of the platform trial, but also how the Bayesian part of the trial rarely varied between each of these. So the model itself was adaptable to completely different patient populations or healthy participants, depending on the trial. And I think that's an incredible strength to have that underpinning bit of steel to the trial, which didn't change while everything else did. So the first trial I'm going to talk about is CST2. So you may have already seen on Say's slide something about CST2. And this is a trial of molnupiravir, an antiviral drug, which again, as Say was saying, it works by essentially causing lethal mutagenesis in the virus. So it makes the virus mutate so much that it can no longer replicate. And this was one of the first drugs that was available as a direct antiviral. We were actually following the healthy participant study that was being done in Fortrea in Leeds by one dose level behind. So we were collecting, this was very live stuff as we were going through doing the phase 1 part of the study. And essentially the phase 1 part of the study is typical agile. You're going to see this a couple more times. So we started on the lowest dose. We randomized 6, 4 that get dosed, 2 that controls, safety evaluated up to day 7, and we can then make the decision about whether we escalate doses, whether we kill, or whether we say, actually, this is the recommended phase 2 dose. And then once that is done, we move into the phase 2 part, which again moves to this Cox regression for time to viral clearance, and the stopping rules as we discussed there, futility and efficacy. And what we did with that was that we took a look at 60 patients in the phase 2. The plan was to extend another 120 in and then re-look at this. In the end, we actually did 2 interim analyses as part of this, but again, it had to go to the 180. And so here are some real live dose toxicity plots. And I think it might just be easy to do a weatherman sort of interpretation here, or weatherman with laser. It's clearly the way forward. So these are the cohorts here. So this is after the 300 milligram twice daily cohort, 600 milligram twice daily cohort, and 800 milligram twice daily cohort. And you can see here, obviously, as we've done the lowest number of patients, we've got quite wide credible intervals here. And we have, the plot suggests that we're going to be creeping very close to our sort of toxicity window by the time we get to 800 milligrams BD. Now, you will note that on the bottom here, on the x-axis, we've actually got 4 dose levels, but here I've only presented 3. And the reason is because if you look at this plot, this is where we were, the model is saying, well, actually, we want you to be closer up to this line, as close as you can be without obviously crossing it kind of thing. And 400 is a bit low on that. So actually, you should be heading to 600. And that's indeed what we did. So we moved up to 600 as our next recommended dose. And you can see as we go through that all of these sort of credible intervals are shrinking down, and we get a good idea of the true toxicity of the molecule that we're testing. Other bits I do want to say is that this wasn't all about, obviously, Bayesian statistics. I know that's what I'm here to talk about. But it was important to get really good data out of these trials as well. So even in the dose escalation with sort of 4 actives in each cohort and 3 cohorts, we were very keen to understand how molnupiravir, or whether molnupiravir got to where it needed to be. So we looked at its active metabolite effectively, and then we talked about nasal swabs. But would you much like it if we stuck a bit of filter paper in your eye 4 times in a morning or afternoon session? But that's what we did, because we collected tears, we collected nasal samples, and we collected saliva samples, which we used then to determine whether the PK matched or was close to the plasma levels. And that's, of course, very important, because where's COVID going to come in? It's going to come in up here, generally. So knowing that you had good drug levels there was very important. And then finally, when we look at the sort of phase 2 data, so here we have the sort of the Cox proportional hazard models, and you can see that actually, as you said, we had the 80% threshold for efficacy, and actually it wasn't reached with molnupiravir on this study. So we got to 75.4% for a hazard ratio greater than 1. But actually it didn't quite meet the pre-specified efficacy criterion as required by the model. And then we also did some very interesting work, with others looking at how things like, because obviously molnupiravir is a mutagen, does this change the virus itself? And does this put you at risk, for example, of developing other variants, etc.? So now I'm going to move on to talk about nitrous oxide, and you'll immediately notice something different here, which is that we include healthy participants for the first time. So nitrous oxide is really interesting. So it's a cheap drug, and this is a repurposed drug, and we don't say his opinions on those. I think that's probably quite right. But it was cheap, and it seemed to have good antiviral activity. Couple of problems. Number one is that nitrous oxide is not the best tolerated dose. It's used to treat, say, parasitic infections, and at the doses at which it's used for, people often become unwell on it. So if they start to vomit, they have lots of diarrhea, all the lovely stuff that you don't really want people with COVID having at the same time. There was another problem. So when you looked at the modelling in terms of the preclinical work, it suggested that the dose that we were using normally for nitrous oxide, poorly tolerated as it is, was actually not going to be enough. We were going to have to take that dose up in order to do that. So again, thinking about the adaptability of Agile, we decided, well, let's add in a healthy volunteer cohort. We can take up to 3 cohorts of 12. And then, depending on whether we reach a effective dose and a tolerable one, then we can take it out to the traditional phase 1B in COVID participants, and then into a phase 2 study. Now, we knew that the dose level was going to be around about 3 grams a day of nitrous oxide. That's what we needed to get to. But there were various ways you could do that, and it depended how you thought that this intolerability was caused. So you could go for example, just a straight split 1500 milligrams twice daily, nice and clean, lovely, excellent. Or you could go for 1000 milligrams split 3 times daily. And then if you really wanted to guarantee it working, you'd whack them with 3.5 grams in an asymmetric dose. So you'd give, the sort of 1500 milligrams and then 2000 milligrams. And so we actually used the models to help us understand how this might pan out and what would be the best way. Now, one of this was based on the likelihood of toxicity, of course. And of course, when you think about it, if you think that, for example, the toxicity is mostly driven by the sort of maximum dose you give, i.e. the maximum concentration you achieve, then the obvious way to start is to go sort of 3 times daily, then twice daily, and then the asymmetric dose. So you're slowly increasing the doses, and you're not worried too much about that. But actually, when you looked at the modelling data, that was unlikely to work. So the chances of reaching a target dose probability was actually very low. And so we went in the end for 1500 milligrams twice daily in order to have the best option in terms of making the correct dose first time, but also having the lower risk of toxicity as compared to doing the asymmetric dose. Because if we gave the asymmetric dose, we would almost certainly, definitely meet the requirements for the PK of nitrous oxide. But actually, it would have probably made everyone sick. And you'll be pleased to know there was a happy end to this, that we had the first cohort of healthy participants. I will say, for one horrible moment, I walked into the unit, myself and Lauren Walker, who was the candidate chief investigator for this study. Lauren and I walked into the unit to see our first participants come back 3 days into their treatment, a lovely shade of yellow. We thought, oh my God, we've just killed their livers. And then immediately thought, oh, wait a minute, doesn't nitrous oxide stain everything yellow? And indeed, their livers were fine, but their tears, their saliva, their urine, everything that came out of them was stained yellow. So we had some very entertaining adverse events, which I shan't go into because it's far too early in the day to do so, but you can imagine. And now I'm going to talk in slightly less detail about a few other studies. And in particular, I'm going to first of all chat about VIR-7832. So this is a monoclonal antibody targeted against the spike protein. But as we've highlighted, there are problems with monoclonal antibodies and the COVID virus. Because if you cover up the spike protein with lots of antibody, then the immune system is unlikely to go, oh, hello, I recognize you, and then develop immunity against the virus. There's a lower chance of it. So VIR-7832 was a first-in-human study using an immunostimulatory antibody. So it was designed to tickle the immune system by a modification made in its structure. And I was candidate chief investigator for this study, and it was slightly terrifying because we had to do the first dose calculations and things like that. And I remember distinctly the moment when we gave the first dose as we were dosing the sentinel pair, and I was literally gripping my the sides of the seat going, oh my God, is this actually going to work? And we're not going to harm someone, etc., etc. But of course, part of the reason why we didn't was because, you know, we had robustly modelled out the likelihood of toxicity and had chosen the doses appropriately. And indeed, at the end of the study, you can see, well, at the end of the phase 1 study, you can see here, this is the 500 milligram dose level. These are the actual dose toxicity plots. And as you can see, the additional toxicity above control that the model was estimating was actually only 7.8%. But that was a factor of getting everything right with the modelling to begin with, and then using the model to help us move through the study. One of the things, of course, the model didn't do was to capture things that were not DLTs, i.e. they didn't reach CTCAE3. And that was a challenge because we actually did have to pause during the study because we had participants who developed a skin rash, the same skin rash, a lichenoid skin reaction, which of course is a classic association with monoclonal antibodies. And it was a classic timescale of 8 weeks after exposure, etc. So we had to pause really to wait for us to gather all of those data. So we had to make some changes on the basis of observed data rather than model data, but nonetheless, it worked exceptionally well. And again, just to illustrate other bits, nothing particularly exciting here, but the sort of viral elimination curves for the 3 doses of VIR-7832, and then lots of PK stuff here as well, which is interesting, but the antibody behaved exactly as we thought it would. One of the things about CST5, which I always like to point out here, there's no one here from the MHRA? Just checking, just checking. Please identify yourself or else we will have a sniper take you out later. But one of the things was that this obviously was in the middle of the pandemic. And so trying to get these drugs into patients as quickly as possible meant we had to do some pretty weird things. So one of them was giving, for the first dose, 50 milligrams, it was a tiny amount of fluid. So it's 2 mils the dose was in, which was given in a syringe like that, okay? And then, of course, you have the line which connects to the patient down there, which has also got a volume too. So you've got 2 mils in there. But once that's got in, you've got a volume of antibody there, which is actually about 50% of the dose. So conventionally, what you would do is that you would just whack it through over an hour and then flush the line. That's conventional ways of doing things. But it was very clear that actually that would be a very bad thing to do because we give half the dose of immunostimulatory antibody within a second or two, straight into people's blood. So with the help of Tesco's food colouring and some maths, so green is antibody, red is the flush, we modelled how quickly it would go through the line and came up with the infusion rates, which again were given then out to other units throughout the UK that were conducting this trial. So weird and wonderful stuff in Agile, basically. Now, at the time of CST5 coming up to the end of its dose escalation and just going into its phase 2 study, things began to change in a very big way. SARS-CoV-2 were very, very fond, as they were saying, of changing. And things like monoclonal antibodies, which are highly specific, will become ineffective when their targets change, i.e. they don't have a great spectrum. And of course, by this time, we had higher levels of population immunity, in inverted commas, from recurrent viral infections. And we also had lots of vaccinated people. And we also had the fact that with Omicron, which had come along at this time, fewer people were being harmed if they were otherwise healthy. So it was a very different pandemic. And so we had to think again quite rapidly about, well, what are the sort of things that are actually important to be able to demonstrate, asking the right questions, as it were. And in particular, we thought about things like combination therapies, whether you want to give higher doses of monoclonal antibodies. We didn't go down that route. And then thinking about the type of population being included in the trials. What are the relevant people who are going to be harmed by COVID, as opposed to a general population that's probably going to do absolutely fine if they get the infection. So CST6 is an example of this change in practice. This is favipiravir, another antiviral. And this was the first time that intravenous favipiravir had been given in COVID patients. And we were going up by quite a dose range as we sort of modelled out, 600 up to 2.4 grams. But the important thing here was that this reflected a very different patient group from the patients with mild to moderate COVID that we had previously recruited into the clinical trial. These were much sicker patients who were hospitalised. They were much older. Thanks. I'll try and be a little bit, but I'm going to do what Say did and basically blatantly ignore it. And ultimately, I think the first patient we dosed had 3 limbs. So we were missing a limb with the first patient. And if you look at the dose toxicity profiles here, then you can see that when we first went in at 600 milligrams, it looks very bad, basically. But part of this was because there was a much greater rate of DLTs, and we had not previously looked at relatedness as being important. And so we developed a clinical adjudication committee, blinded to allocation, treatment allocation, which allowed us then to bring this back. And by the time we get to 2,400 milligrams, that curve is looking a lot more like the ones that we've come to be used to with other ones in the platform. Very quickly, I'll talk about CST8, which was the first of the combination platforms, but this is doing things the other way around. Because both licensed drugs, having molnupiravir and Paxlovid, we went in at full dose for molnupiravir, and Paxlovid is a fixed dose anyway. But we managed to have models that allowed us to be able to look at the de-escalation to see whether we needed to de-escalate the molnupiravir. So we started up here. We recruited 24, and that clearly recommended the dose in combination for onward into other platform trials at later phases. And then finally, last 2 slides, I promise, Pavel. So moving into the future. So Say's already talked about what are relevant outcomes, what are the relevant populations. Are they all comers, hospitalised, at risk of progression? Should we assess combinations? And so CST9, which is the current study, which is about to start, uses a completely different outcome measure, co-primary outcome of viral clearance and time symptom resolution. We're including populations at higher risk of disease, those that would be eligible for treatment currently, and includes both the IMP alone, IMP in combination, and standard of care arms. And I think I think what I really want to say, rather than that conclusion slide, is what I hope I've demonstrated to you is that the methodologies used in Agile were incredibly powerful for us, and they allowed us as clinicians to make decisions in a much more robust way, but also in a way that was justifiable and helped support regulatory decisions, etc. And so hopefully that's what I've managed to convince you of in the last 42, 43 minutes. And just to say, these are the huge number of people who were involved in Agile, including our funders. There is the CRF team who were instrumental in delivering a lot of this work. And I'm indebted to them, as I am always, for all the work we do. So thank you very much indeed.